Good afternoon, everyone. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks for joining us on this week's COVID-19 clinical webinar. As always, we will have Q&A at the end of the presentation, so if you could please submit your questions in the chat box at the bottom of the control panel at any time during the presentation, you can enter those. We are also recording this webinar, and we'll send out an email to all of the invitees with a link to the recording and also any links to resources that are mentioned during the presentation. At this time, I'd like to turn it over to Sound's founder and CEO, Dr. Rob Bessler, to share a few thoughts before we get started. Rob?
Hey, Mark. Good afternoon, everyone. Really glad to be with you all. And one of my favorite things to be part of is when we all come together and collectively share our knowledge about giving better care to our patients. Unbelievable time, of course, and so appreciative for everyone's continued efforts at every level inside of Sound. I did want to just share, Mark, an email I got yesterday from one of our chiefs. When I reached out to her, I knew she was hospitalized and was in recovery, thankfully. And her response back to me is a treasure and something I wanted to share with each of you. Her response was, "Surreal 21 days. I ignored a small, low voice of panic the entire time so that I could cope. Glad my doctors didn't show me my chest x-ray until the day before I left. The x-ray was too similar to those people I had just cared for in the ICU and intubated. Since returning home on April 23rd to my kids and husband, I had a few days of sudden tears that appeared from out of nowhere. No rhyme or reason. So glad to be alive and with my family, watching my apple trees bloom, my garden fill in, the birds at the bird feeders. There's a swallow that is building a nest right dead center of my patio in one of my bird boxes that has become a daily thing. I'm relishing dinner at the table with a lively, opinionated family that results in arguments, laughter, eye rolling, etc. My grown kids will plop next to mom and just lean in, cuddle, and just be. I'm very grateful to have survived, minimally affected. It'll be good to return to work once this exhausting cough and shortness of breath resolve. Thank you for reaching out." Just so lucky to work and so honored to be with you all here today. So thanks, Mark, for letting me share.
Thank you for sharing that, and so grateful that this person felt comfortable sharing that with you. Well, much of the credit goes to all of our clinicians on the front lines and to the crew that has been providing these webinars. And so why don't we jump right in? And I'd like to just introduce our expert presenters, our three CMOs, Nate Ruck from Emergency Medicine, Dr. Greg Johnson from Sound Hospital Medicine, and Dr. Sergio Zanotti from Sound Critical Care. Take it away, guys.
Thanks, Mark. Appreciate your going over that. And as Rob stated, just a tremendous amount of gratitude that we have and continue to be humbled by the response that everyone has had with respect to caring for patients in their communities, caring for each other, and really just doing such a remarkable job in leading the effort against this particular condition. For today's agenda, we're going to go over our typical update with respect to the organization's view of what's going on with COVID, as well as what's happening with our volumes. We'll speak a little bit about the vaccines, provide some clinical guidance around intubation and the role of Remdesivir, and then a little bit of discussion with respect to, I don't know that we're calling it post-COVID, but certainly just how we're addressing healthcare and what we think some of the clinical issues are going to be with healthcare in the post-immediate COVID era, and then our usual Q&A. So that will roll straight into the Sound update. By now, you've seen a number of these particular slides, with the top, again, representing the total number of admissions for COVID or related conditions, as well as the screened admissions and the total number of confirmed cases that exist. As you can see, the number is going down, which is consistent with what a lot of people are considering with respect to reopening for elective surgical cases or just the hospitals being closer to functioning the way that they historically functioned as we worked in them. Again, great deal of thanks to our critical care and hospital medicine teams for continuing to enter this additional information since this continues to be shared with not only internally but with external organizations. Next slide, please. The cases by age group remain very consistent in terms of suspected and confirmed cases. I think our eyes, or at least my eyes, continue to go to the mortality. And again, noting that really age 65 and older are consistent with age 50 and older, higher mortality, but these have again held pretty firm with respect to our internal data and remain consistent with what we've seen externally reported as well. So we'll slide into what's going on with respect to vaccines, since that's been in a lot of the lay media recently, and with Dr. Fauci having a number of interviews, wanted to be able to speak to that specifically. And before I get into this, I encourage folks to take a look at the SARS-CoV-2 status report in the journal called Immunity. When these slides are sent out, the hyperlink will take you directly to this particular report, but this was done approximately 2 weeks ago, and it helps to guide at least some of the description of not only what's happening, but what some of the considerations are with respect to the production of a vaccine. You can see the entire virion of SARS-CoV-2 and the particular highlight at the top of the spike or S protein, which has the binding domain. We'll spend a little bit of time talking about that, because if we're talking about where vaccines are being focused and where it says current stage, various aspects of the protein or the virion are being considered in terms of vaccine, but the S protein seems to be the most likely, and we'll get into a little bit of why that is as a target area for the vaccine as we move forward. Next slide, please. So the first aspect is taking really the information that's been received from prior pandemics. For those that recall, a number of us were still in clinical care for H1N1. It was a pandemic. It was a much faster release of the vaccine, primarily because it was change of strain, but it still took 6 months to get that redistributed change of vaccine out into the market, which actually ended up missing the second wave of disease when it occurred. And so I think that part of what is framing the considerations around the SARS-CoV-2 vaccine is really about production, about the timeline in terms of getting that out to market, because it does materially affect the amount of disease that is noted clinically, both in hospitals as well as in primary care facilities. For SARS-CoV-1 and MERS-CoV coronaviruses, there are a number of lessons learned in terms of the vaccine development for those. Although you probably haven't heard of vaccines associated with these, and that's because they were not necessarily stopped, but slowed in terms of evaluation for a variety of reasons, including MERS-CoV, simply because there was material minimizing of the disease burden from non-therapeutic, non-pharmaceutical methods. And so there was then decreased funding and decreased urgency. There are animal models for these other coronaviruses, but one of the lessons learned from these is that in the creation of vaccines, at least in animal models, there was specifically disease enhancement. Very specifically, there was an increased eosinophil response in the lungs, and obviously that sort of, I hate to call it allergic, but that enhanced reaction was of significant concern, and part of the reason why it's informing decisions about the SARS-CoV-2 vaccine. As mentioned before, the S protein is really the target. This is where it interacts with the ACE2 receptor within humans, and in the mouse model, This is ultimately neutralizing the virus. A lot of this was determined from the SARS-CoV-1 vaccine trials, which helps to advance what has been done with the SARS-CoV-2 vaccine. Other particular interests that are informing, and I think part of the reason why there is some level of optimism about the creation of a SARS-CoV-2 vaccine is that there is cross-reactivity in of the neutralizing monoclonal antibodies. And so that essentially gives us some guidance as to the fact that, hey, we've already created something in the SARS-CoV-1 model. Can that be replicated or at least considered in terms of what's for COVID-2? Next slide, please. Now, obviously, there are other considerations that go along with this, and some of these considerations goes along with the fact that this is a novel coronavirus, and therefore creates concerns about just things that we don't know. So one of the things we don't know is about the long-lived antibody response and whether or not there is the ability for reinfection after a period of time. We've mentioned in these webinars previously that reinfection hasn't been noted in the short term, but again, we don't know when that short term exists. As you can see in the second bullet point, for the other coronaviruses, this antibody titer essentially waned after 2 to 3 years or were super weak at the beginning, which means that you have to consider these in terms of what is essentially the timeline for application of any vaccine that goes forward, and how frequently is their dosing. The third component or third consideration that goes along here is what happens for our over 50 population. And as you saw, that's obviously more severe pathology, higher incidence of mortality with respect to those. And so what do we do? And the concerns, or at least what's been learned before, is that older individuals are responding less well, again, due to immune senescence. And then based on what's happened with influenza virus, that protection requires higher neutralization titers, which may mean higher dosing, may mean that there are a lot of specific considerations of who gets this and what dosing has to be done. And all of those things have to inform how a vaccine is rolled out into the general population. Next slide. And so this table really helps to condense at least the thoughts about what the approaches for vaccines are. And you can see the vast majority of them are focused on the S protein, although what we've historically known as vaccines in terms of live attenuated or inactivated vaccines exists and takes on the entire virion. I think a lot of the excitement around the fact of, or the availability of this for humans is what's listed there, which is that we have existing platforms that we know have worked at least in other particular instances. And so again, it's taking lessons learned or lessons that have been applied and applying it to the SARS-CoV-2 vaccine. You can see there that there are a number of advantages. I think for live attenuated and inactive vaccines, the biggest issue is you need a lot more virus, and it has to be managed and handled in a very specific way. And we currently don't have that level of expertise nor the number of facilities to be able to do that for this to be done quickly. It's likely it can be done, but for these traditional types of vaccines, that's going to be a significant challenge. The advantage of the recombinant protein vaccine or the viral vector-based is that we don't need additional virus. We do have excellent information that at least these platforms work, but it's going to be about how quickly we can produce this, and ultimately whether or not, again, it's not about the platforms being safe, but whether or not they're ultimately effective in limiting the actual disease process. Before we swing into the other clinical pieces, the real component that's coming into this is, hey, when can we expect this? And again, I go back to some of Dr. Fauci's interviews, the one that was in National Geographic, but you can find them in various places. And I think because of the fact that there was advanced work on other coronaviruses, there's optimism that a vaccine is going to be available this year. The availability is one thing, it's the ability to produce that's another, and the ability to get it to the market, and decisions that are going to have to be made with respect to, do healthcare workers get this? Is this particularly distributed for individuals in skilled nursing facilities or long-term care facilities? There are a lot of additional decisions that have to be made before this has a material impact on what's happening for patients and for overall care. However, it's our desire, as more information is provided, to continue to keep you abreast. And again, I encourage people to take a look at the status report just from a couple of weeks ago. I think it provides a lot of detailed guidance. With that, I'm going to transition over to Sergio, and he'll talk about the clinical guidance.
Thanks, Greg. And again, want to reiterate how appreciative and proud we are of all the teams and all the work that they've done. Today, for the clinical guidance portion, there were two questions that we wanted to address. One is, when should we intubate a patient with COVID-19, which is obviously a topic of debate and a moving target, but I think that one of great interest for all our clinicians, regardless of their service line. And the second one, related to what's going on in the news, is what is the role of Remdesivir in COVID-19, and trying to answer that question with the best available data that we have. So we'll start with the first question. Next slide, please, Nate. In terms of when should we intubate a patient with COVID-19, I think that ultimately, like any decision to intubate, it is based on clinical decision making at the bedside. It's very interesting that a lot of times I think we fall into circular thinking with these patients with COVID and other respiratory diseases, and we talk about the patient required intubation or the patient requires mechanical ventilation. And the truth is that many times the patients don't require, but we make a decision to proactively proceed with intubation and put them on mechanical ventilation. Unless somebody has a cardiac arrest or has a very clear indication that they can't really breathe or are in full arrest, they might not require intubation, but we choose to do it because we think it's best for the patient. So along those lines, when we think about COVID, I think three areas that I think are important are hypoxemia and vital signs, and we'll talk about that, how particularly impacts COVID. Work of breathing, and this concept that we talked about, I think in other webinars, the idea that you can still cause injury to the lung on CPAP, on BiPAP, spontaneously breathing, and really trying to address that in some patients. And then there's other clinical factors that might include, like if somebody's vasoactively impaired, or if they're hemodynamically unstable, if they obviously are unconscious, don't have a gag reflex, et cetera, et cetera. There's a lot of other reasons why we might proceed with intubation a lot quicker. But let's try to figure out how the first two especially fall into the decision making for COVID-19 patients. Next slide, please. And one of the things I wanted to also illustrate is the progression of the pulmonary disease in patients who are hospitalized with COVID-19. This is a slide that I've shown before. It's from the large series in Lancet Infectious Disease from 83 patients in Wuhan, China. And what you can see in this particular patient, the CT scan on day 5, day 15, and day 20 shows a significant progression from what seems to be basically some ground glass opacities and not a lot of infiltrate to what we would call a full-blown bilateral dense infiltrates, ground glass opacity on top of that, pleural effusions, more consistent with ARDS. And I think a lot of times it might depend where we are in this continuum in terms of what might be best for the patients, and we're trying to understand that. Some experts have pointed out that not all patients that end up in the ICU or present to the hospital with severe respiratory distress and COVID present with a picture that's consistent like C, which would be our typical ARDS. We're still trying to understand, I mean, these phenotypes, whether these just are expressions of the same disease. But I think that it's important to recognize that some patients might be earlier in their disease or might have less impact on their x-rays, and some might have more, But ultimately, also, it's important to understand that the X-ray alone is not a determining factor for whether somebody would benefit or needs mechanical ventilation. Next slide, please. So early on, I think that the advice given by the first guidelines from WHO, CDC, and others was for people to consider early intubation. And I think that that still applies. I think that everybody agrees that we should not delay intubation in patients who need intubation. I think the more difficult question is to figure out who really needs intubation and who can be treated without being intubated. And that's where I think we're struggling more at the bedside. And that's why I wanted to kind of give you a little bit more information to help make those decisions. So early on, when people heard early intubation, I think a lot of this was related to balancing the concerns of, on the left, of transmission of COVID-19 with aerosolization on patients who were supported with high flow oxygen or non-invasive ventilation. Plus, on the other hand, in the first series that came out of China, critically ill patients, it was noted that patients who were on non-invasive ventilation for some time before getting intubated seemed to have a worse outcome. And when we pair that with experiences from SARS and MERS, it seemed like not only there might be an increased risk of contagion with certain modalities, but also there might be a failure to rescue or a high failure rate, which made people say, well, maybe we should intubate these patients as early as possible. And a lot of people recognize that as we were treating these patients, that once people were going up on their oxygen requirements above 6 liters per minute, it seemed to be kind of an inflection point where more and more people would get very sick very quickly, and to the point where some practices were actually just intubating people early on who were requiring more than 6 liters per minute. Now, that pendulum has swung back and forth, and I think as we understand things a little bit differently, now I think that we're trying to take a more measured approach and really try to identify who really needs to be intubated and do that as soon as possible, but recognizing that there's a number of patients who might be able to be managed without intubation and who we might benefit by preventing potential lung injury from mechanical ventilation if possible in these patients. Next slide. So I think that one of the observations that a lot of clinicians have made and those who have treated COVID patients have probably seen both on the floors, the ED, and in the ICU, and I certainly have seen this with a lot of our patients, is that these patients might present extremely hypoxic with a FiO2 to PO2 ratios that definitely fall in the realm of ARDS, yet a lot of times early on, they don't have significant work of breathing. They seem to be comfortable. They seem to be able to converse when they're at rest. They seem to be able to tolerate with oxygen. And I think that one of the things that we have learned is probably that we should not intubate COVID-19 patients solely on the basis of hypoxemia. And a couple of comments I want to make on this are that, first of all, because of the oxyhemoglobin dissociation curve, we don't really know in a patient who might be satting 95% on some supplemental oxygen, where their PaO2 is 60 or 200. So without getting those gases, we might not really have a good idea of how much oxygen they truly require, number one. Number two, a lot of decisions are made based on the PaO2 FiO2 ratio. And once you put somebody on supplemental oxygen, unless you're controlling it through a ventilator, it's very difficult to really know what their FiO2 is. I mean, on 2 liters of nasal cannula, you could be getting from 21% to 35% of FiO2. And as you escalate that, that range becomes wider. So I think it's very important to recognize that once people are on oxygen, which is usually the case when I see them, it's very difficult to really figure out what their true FiO2 is and where they really stand until they're intubated. The last thing I want to mention is that, as you all know, there are different causes of hypoxemia. Most of the patients with COVID-19 will have hypoxemia with an increased AA gradient if you measure it through an ABG. And most of these patients either will have some sort of intrapulmonary shunt or some ventilation perfusion mismatch, which we think is more prominent, especially in those patients who have x-rays that are not very, very impressive. So I think that initially we were reacting to a low oxygen, but not putting things into the context that some of these patients are able to tolerate that lower oxygen and that they not have an increased work of breathing. And then a lot of times when we give them oxygen, we could improve that oxygenation, and by keeping a close tab on them, we might be able to support especially younger patients who responded to oxygen without having to put them on a mechanical ventilation, and that might have advantages for those patients. Not to mention that also in cases where we have tremendous amount of cases like occurred in New York, every ventilator that you don't use is a ventilator you have available for another patient, and that is something I think also that places like Italy and New York very quickly realized that by intubating everybody very early, A, they were burning up their resources, but B, they also might be putting people on mechanical ventilation who could have been treated without it. So just by the degree of hypoxemia when they approach, I wouldn't decide to intubate, and I think that we should evaluate a little further. Next slide, please. I do believe that something that is very valuable in terms of determining when we should intubate somebody early is their work of breathing. And the idea that we have recognized before COVID is that when you place somebody on mechanical ventilation, by giving them volumes that can overdistend their alveoli and by giving them pressures that swing their alveolar and transpulmonary pressures, you can cause significant lung injury, what we know as barotrauma, volute trauma, or also stress and strain. And that has been the single element that we have addressed in large clinical trials to improve mortality in patients with ARDS. What we also know now is that those same dynamics of transpulmonary pressure swings, negative and positive, and very large tidal volumes can occur in patients who are being treated with supplemental BiPAP or high flow oxygen or breathing spontaneously when they're in respiratory distress, and that those can also potentiate or increase lung injury, leading to worse outcomes. So I think that one of the things that we want to do as clinicians is really recognize those patients who are really having an increased work of breathing and at high risk of producing what we call patient self-induced lung injury. And that there's a couple of things that you can do very quickly on the physical exam. Number one shows, palpating the sternomastoid. And if you feel that there's fasciculations or contraction of the sternomastoid, that is a very clear sign that the patient probably has an increased work of breathing. Putting your finger on the cricoid cartilage. If you feel that with deep inspiration that cartilage is tugging, you have tracheal tugging, which is produced by large swings in intrapleural pressure from the diaphragm exerting extra force, again, a very clear sign that somebody has increased work of breathing. Observation of the suprasternal fossa and seeing retractions with the deep inspiration, same thing with intercostal spaces, and also if you can see that somebody's diaphoretic. These are all very easily accessible at the bedside observations that would indicate a increased work of breathing and a high likelihood of the patient self-inducing lung injury. And I think that when you see this in combination with increasing oxygen use or in combination with low sats, clearly that's an indication that we should go ahead and intubate the patient immediately. The other aspect that I think is important is always to follow the respiratory rate. I have seen patients who actually present with very low sats, but respiratory rates that are normal with COVID-19. Those patients probably can be supported either with high flow oxygen or supplemental oxygen, or in some cases non-invasive, and might not require intubation. But if the respiratory rate starts going up in conjunction with all these findings, I think that that would be an indication to proceed with intubation. Next slide, please. So I think that the key here is when we're trying to answer that first question is, if I see a patient with COVID-19 and they're hypoxic, do they have an indication for endotracheal intubation? So if somebody was in shock, was altered, had cardiac arrest, for sure. If I clearly see that they are hypoxic and struggling with increased work of breathing, I would definitely intubate them. And I think that we all agree that in those cases, we don't delay. The most expert person does the intubation. We use proper PPE. We minimize the staff in the room. And like I said multiple times in that box on the left, we use video laryngoscopy when possible to improve our first pass rate and to protect the operator by distancing them from the airway. If they don't have a clear indication of intubation, or they look like they're doing okay with supplemental oxygen, I think what's very important is to monitor the patient closely, to target the SaO2, I would say above 90%, but there's no need to go very high because, like I said, as you get to that flat portion of the dissociation curve, you might be 96%, and that could be a PaO2 of 60 or it could be a PaO2 of 250. So we don't need amine to keep increasing the oxygen to keep the sats that high, but definitely want to keep them above 90% and follow that. And again, appropriate infection control precautions I think are very important. Now, if the patient is not tolerating regular nasal cannula, or we think that they need more oxygen, I would think that most people would agree that the first thing to consider would be high flow nasal cannula. And that is based on a lower belief of a risk of aerosolization of droplets. And number two, because there's better track record with respiratory failure in ARDS with high flow nasal cannula than with non-invasive positive pressure ventilation. If you don't have that, or you decide to consider non-invasive, I think that the two things that apply to both of these is that you need to monitor the patients very closely in short intervals, looking for that potential deterioration, increased work of breathing, and that's when you intubate them. And that if you think that the patient is having an increased work of breathing or not tolerating things very well, you should not delay intubation and move forward with intubation. So I think that those are two things that are very important when we use high flow nasal cannula and or non-invasive positive pressure ventilation. Lastly, I think it's important to remind people that we probably have an increased risk of aerosolization of droplets, and in these patients, we should optimize our PPE with the use of N95s when available, but also if you had negative pressure rooms, these are the patients that you would probably prefer to have in a negative pressure room. So that kind of summarizes the way we're thinking about intubation right now. And again, I think ultimately what it's telling us is that we still have to assess patients individually, and there's not one size that fits all, and that just because they're on 6 liters, everybody gets intubated, which I think was a more common occurrence early on in the pandemic. Next slide. So as you all are very aware, in the last several days, we have seen a lot of press reports on Remdesivir being positive, Remdesivir being approved by the FDA, Remdesivir being a game changer. We've heard that word so many times. So I felt that it was important for us as clinicians to really understand where Remdesivir fits right now and what has been approved or not approved and how this will be used or not used at the bedside. Next slide, please. So Remdesivir as a treatment for COVID-19, its original experimental name was GS5734. Actually, they found it's a nucleoside analog prodrug, and what they did is they were testing for inhibition in vitro for various coronaviruses and flaviviruses, which is the Ebola family, some years ago, and that's how this compound emerged. And it was initially tested for Ebola, but didn't work, so it was eventually shelved. But it has shown that it inhibits replication in animal cultures for MERS, for SARS-CoV-1, and for SARS-CoV-2. Now, there are many, many drugs that inhibit replication in vitro that when they test it clinically don't really succeed in inhibiting the virus in vivo. But as you can see in this slide from the JAMA paper, you can see that Remdesivir falls here in terms of inhibiting the viral replication of the RNA-dependent and RNA polymerase, the RDRP, which is a key element in the virus replicating. So the idea is that it would block that at that point. Next slide. So based on these in vitro studies, early on in the pandemic, Remdesivir was available via compassionate use for very sick patients. And this is a report that was published in the New England Journal of Medicine last month, where they basically showed 61 patients that received Remdesivir in a compassionate fashion. And you can see here, actually, what's very interesting about this trial is that they lost 8 patients, so they don't have follow-up for 8 patients, which is it's a significant percent of 61, and that's usually a big problem when you're reporting anything when you have unfollowed patients, because if all those patients died, obviously the results would be very different. But this is just, I think, a proof of concept that basically they gave you the 53 patients that they followed, and they say that 68 of them got better in some way. Some died, some got worse. But really all they could say from this compassionate use of remdesivir is that it wasn't as, there was no toxicity, it didn't kill people directly as we know, and maybe this is a basis for moving this forward to some clinical trials. Next. The first and only randomized trial has been published is a trial that was done in China, where they randomized, double-blind, placebo-controlled, multi-center trial. They had a randomization regimen of 2-to-1, so they were trying to get more people on the drug. They used a 10-day course, which is a 200 milligram bolus IV on the first day, followed by 100 milligrams IV every day from days 2 to 10. And basically, they randomized 158 patients to remdesivir, 79 patients to placebo, and their primary endpoint was the time to clinical improvement, as defined by a scale of 6 points, and you wanted to go 2 points or better by day 28. So ultimately, what you see here in the graphs are the clinical improvement in the first slide with red and is remdesivir and the control is blue, and there was no significant difference. And then you have the viral clearance in terms of the viral load. One is from the nasal area and the other one is from a deep swab. And again, no significant difference in the viral clearance. So this actually was a negative study. It was stopped a little bit earlier because the pandemic cooled down in Wuhan, but it was reported as a negative study. And of interest, there were similar reported adverse events in the placebo and in the percent-wise and in the treatment group, but there were significant more patients who had to stop the drug in the remdesivir group than in the placebo group. So again, I mean, a negative study, it was also not found to be significantly toxic, but the real question is, I mean, the absence of benefit doesn't necessarily prove that there is no benefit, because they felt that they're aiming for more patients. But it is the first randomized placebo-controlled trial, I mean, with over 200 and almost 250 patients, and really there was no effect here. The next study, next slide please, is a study that everybody's referring to on the press. It has not been released to the public. It's the NIH trial that is part of the COVID adaptive trial, and this is what Dr. Fauci talked about. And all we know from what's been released is that they enrolled 1,000 people, plus minus, and that what they saw is that in the treatment arm, the mean time to recovery in those who recovered was around 13 days versus 11 days versus 15 days in the placebo group. So clearly a couple of days, median time recovery was quicker, mortality no difference. And this actually is not seen as a positive trial that supports that remdesivir works. What is seen as a trial that allows us to keep investigating and keep pushing forward to try to find the best way to use remdesivir. And what you see next to it is a May 1st FDA letter sent to Gilead, which basically gave them an emergency use approval, which is not the same as this drug is FDA approved for COVID-19. What they're saying is that based on the available data, we believe that it's more likely that this could be a helpful drug than a harmful drug, and that while this emergency use approval is in process, there are certain patients who could be treated with remdesivir. So let's see what that really means at the bedside. And they are still ongoing in terms of trials, trying to figure out what the right role for remdesivir is. Next slide, please. So right now, the approval authorization, emergency use authorization, is for COVID-19 patients with severe disease, and that is defined as a pulse ox below 94 or equal to 94, below 94 on room air, or the requirement of supplemental oxygen, mechanical ventilation, or ECMO. And there are two regimens that are being recommended. A 10-day regimen for those who are mechanical ventilation and those who are in ECMO, which again is the same one that they use in the Chinese trial, 200 milligram bolus on day 1, and then 9 days of 100 milligrams a day, all IV. And a shorter regimen for those patients who are not intubated, which is a 5-day regimen that is 200 milligrams on day 1 and 100 milligrams every day IV for the next 4 days. Caution, liver and renal failure are thought to be potential problems. One of the things that is commonly seen is elevations in liver enzymes. And there are very clear instructions in terms of the healthcare providers as they use this drug. And what they say is that as the healthcare provider, you must communicate to your patient or caregiver that the FDA has authorized the emergency use of Remdesivir, which is not an FDA-approved drug. The patient or caregiver has the option to accept or refuse Remdesivir. The significant known and potential risk and benefits of Remdesivir and the extent to which such risk and benefits occur are known. And finally, you have to provide information on available alternative treatments and the risk and benefits of those, which we don't have any. But I think that what's very important is that Remdesivir is not going to be available just to prescribe. All the Remdesivir available will be distributed by the government and be allocated to hospitals. If you're going to use this drug, you're going to need to provide informed consent to families. It's still very much thought to be experimental. If you use this drug outside of the context of a clinical trial, an official clinical trial, as a provider, you still have to report any side effects or any complications to the FDA. And next slide, please. And it's also very clear that besides all this information that you have to share, there's a fact sheet for providers and the link is there. But they also, in the letter and everywhere that they talk about, they tell you that as a provider, you have to give a fact sheet for patients and families to the patients and families as part of the consent. And that is available through that download. So I do think that we're going to hear more about Remdesivir. Clearly, there is some hope that it might work, but it's still experimental. And right now, you just couldn't go and prescribe it because your hospital probably wouldn't have it. So I'll stop there and hand it over to Nate.
Thanks, Sergio. So I'm going to start off with a little bit of an update on return to work criteria for healthcare workers. Late last week, the CDC updated their guidelines and made some changes that are worth noting to the symptom-based pathway. And they extended the amount of time since symptoms first appeared is now 10 days. So to return to work after having documented or suspected infection, you need to meet all 3 of these criteria. 10 days have to have elapsed since your symptoms first appeared. Your symptoms need to be improving, and you need to be afebrile for 72 hours without the use of fever-reducing medications. And it's also worth saying that these criteria are meant to be guidelines, and if you're in an area that's affected by labor shortages or there are mitigating factors which can allow your local infection control department, your local health department to adjust what criteria are used. And then the final bullet point is something that's really worth emphasizing. We've talked a lot on these webinars about the pitfalls of PCR testing, and it now is clear that at least some fraction of patients that have prolonged positivity of the reverse transcriptase PCR test are shedding inactive viral fragments that the test is amplifying and then detecting, and they don't in fact have viral cultures which show infectious material. So it's possible to have persistent positivity but not be infectious. Now, this is an area where there's still research ongoing, and I don't think anyone has all the answers here, but that's an important pearl with regard to using the testing pathway for return to work. Now, what about an asymptomatic healthcare provider that has a positive test but doesn't have symptoms? You can again use either arm of the pathway to have that person return to work. You can use a symptom-based or test-based strategy. And again, worth underlying is that detecting RNA via PCR doesn't necessarily mean that infectious virus is present. And the hyperlink at the bottom of this slide gives access to more detail than anyone would want, but the kind of full guidelines from the CDC. So this pandemic has placed challenges on the healthcare system that are certainly going to catalyze some lasting change, not just to healthcare, but to society in general. And what will be different aside from masks being common in the public sphere? I don't certainly don't think that we have all the answers, but there are some things that are fairly clear. And one of those is that virtual care in the form of telemedicine is going to become much more common. If you look at the experience of health systems who had relatively well-developed infrastructure, their growth has been nothing short of explosive. Here, where I am speaking from in Philadelphia, Jefferson Health has a system called Jeff Connect, and in February of this year, they were seeing about 50 visits per day virtually through their Jeff Connect system. And as of this past week, they were seeing just over 3,000 per day. And that type of, this infection just has really removed a lot of barriers. The other thing that's happening is that, digital natives are becoming old enough to become consumers of healthcare, and they're so comfortable with virtual interactions that, that too is going to be an accelerant for telemedicine. The third bullet point, really one of the things that every hospital is struggling with is that people listened a little too well to the stay-at-home order, and to the point where they've really become fearful of presenting for any reason to an acute care hospital. And we're already seeing larger facilities with multiple buildings dedicate space to elective care that's completely separate and to be kept clean. And I think that's a trend that will continue, and in many cases we'll have to adapt our workflow to match that patient preference. Universal source control is something that a lot of hospitals continue to do. I'm not sure what the endpoint for that is. I don't think, as long as there's any prevalence in the community that's served, that will end. So for the foreseeable future, with undifferentiated patients and certainly all those in the emergency department, that's likely to continue. The final point on this slide, contact tracing and infection control, I think is really going to become important as restrictions are relaxed and as more businesses open and there's more interaction. There are certainly going to be, compartmentalized outbreaks of disease and even, super spreader events at moderate sized gatherings. And how contact tracing occurs and what role healthcare professionals are going to play in that remains to be seen. I know Governor Cuomo in New York has said that they don't really plan to enter the final phase of reopening until they have 30 contact tracers employed for every 100,000 residents. So that's, you think about the 20 million residents of New York, that's a substantial workforce that needs to be trained and spun up. There's been a lot of discussion of utilizing cell phones, and each cell phone has a unique identifier. And one of the things that South Korea has done to augment their tracking, as a lot of you are aware of from the articles in the lay press, is use electronic tracking. And what role that, how technology is going to augment tracking and where the balance lies between, personal freedom and autonomy and protecting others from infection, I think is uncharted water that we're going to be navigating in the very near future. So what does this mean for our practices? I think that the opening up of America, again, is going to be unevenly distributed geographically based on disease prevalence and based on resource availability. Many communities are still going to have substantial COVID-19, prevalence. The peak resource utilization in many states and the growth rate of new cases has contracted, but there are others that are still earlier in that curve. I also think we're starting to see in some markets release of pent-up demand. And, as I alluded to earlier, the public really listened too well to the message to stay home. And there's an article that may have been released this week or maybe not, that was on the preprint server for JACC, the Journal of the American College of Cardiology. And it showed, it was a multi-center trial looking at the incidence of ST elevation MI during the COVID pandemic. And it showed nearly a 40% decline in STEMI. And I don't think there's anyone, cardiologist, emergency physician, hospital medicine clinician or otherwise, who believes that there was a 40% decline in STEMIs. What that means is that people are so afraid to present to a hospital that they're staying home with heart attacks. And certainly there's a kind of public relations component here where we're going to need to partner with our facilities to figure out how to get this message out in a way where, people who appropriately need to utilize hospitals do so. I think it's also likely that, we're going to continue to see escalating consequences of isolation. Humans are social creatures, and many who are already isolated have had that isolation taken to another level. And that's going to have, a number of consequences, whether it's, exacerbation of psychiatric disease or, under treatment or absence of treatment for underlying medical conditions. We're already seeing that in some markets, and that's likely to continue. I'm also concerned that the issues around PPE and its availability, as ambulatory surgery begins, many facilities are using a more PPE heavy strategy for their operating rooms, and how widespread opening of ambulatory procedures is going to impact PPE availability for ICUs, hospital medicine, and emergency medicine remains to be seen, but is something I think we need to keep a close eye on. And provider well-being, I think there are many silver linings to this pandemic, whether you look at being better prepared for the next pandemic, whether you look at, sick leave for low-wage workers, but one that's, certainly there for healthcare is I think everybody is going to have a little bit of an increased focus on the well-being of providers and what it means to do the job that all those on this call are doing. And with that being said, I think many of you will recognize this person. This is Dr. Lorna Breen. She's was an emergency physician in New York City and Manhattan who's on the front line of treating COVID, and she committed suicide 9 days ago. And May is National Mental Health Awareness Month, which, I think with all the social isolation that's occurring and with the stress that many are under, really getting the message out around suicide and having honest discussion about mental health in medicine and elsewhere really, couldn't come at a more appropriate time. And if you look at the, how suicide breaks down among physicians, female physicians have 4 to 5 times the risk of suicide of women in the general population. And, that's really something that's eye-opening. And I think we all need to be honest about the culture of stoicism and self-reliance that exists in medicine and be vigilant to, how our colleagues are doing, and know that many of those who need help the most may not ask for it. And with that in mind, I'm going to just highlight a couple of resources that are available. So Sound has, an EAP program, which is detailed in the subsequent slides. Some of you may not feel great about reaching out to an employer related resource. So this is the physician support line, which is a group of volunteer psychiatrists who have gotten together to provide, free and confidential, no appointment necessary counseling for those that are involved in caring for patients with COVID. And if this is something that you think might help you, I would encourage you to reach out. We also have, I think we've underlined the importance of self-care on this webinar and on other venues. Previously, we also have, both formal and informal peer support and the EAP that I talked about. Mark Rudolph and his team have done really a fantastic job of aggregating well-being resources, which are available either through Sound Connect or through OWL. So, and this is a screenshot of that web page. I see that we're getting close on time here to the end, so I'm just going to make the remainder of these slides on the resources that are available informational and hand it over to Mark to take us away with some questions. I don't know if you're on mute, Mark, but I'm not hearing you come through on my end. I would encourage.
Thanks, Nate. I'm new to cell phones. I just want to add one thing to Nate's fantastic comments there, which is that the the well-being page is now available via a link that's on the soundphysicians.com main page. There's a button on the banner that says tools, and at the bottom it says well-being portal, which will take you to that page that Nate just showed with all those resources. So we do have just a couple of questions, and the first question is from a colleague who contracted COVID and who unfortunately has been struggling with symptoms for the last 6 weeks, though sounds like, as described by them, as sort of mild to moderate. A couple of these things you've addressed already. The first was the potential for reinfection after recovering. The next part of the question had to do with the significance of a positive test, and I think those two things you've mostly addressed. But the last question has to do with follow-up and the potential for any long-term impacts on respiratory status or other organ systems.
So I'll take that one, and I think that the reality is that we just don't know. I think that clearly the vast majority of people who have COVID recover, and they seem to eventually over time recover back to their baseline. But I still think that there's a lot that we don't know, and probably the follow-up would be recommended. I mean, once negative, to follow up with their PCP, and also, I mean, to reach out to any of us if there's other questions or anything else that we can support. And as we learn more, I think that we'll be able to provide better advice on follow-up. But that's a great question, and I think that what we do know from other viruses, and some of you might have experienced other severe flu or other viruses in the past, it does take, I mean, several weeks for people to get back to normal, and that is not uncommon with when you get a bad case of influenza. And I imagine it would be very similar with COVID, but based on what we know right now, the vast majority of people get back to normal. It might be a prolonged phase of weeks, but we also, I mean, are trying to learn more and more about, are there any residual effects, especially for those who had severe disease that required hospitalization or intensive care.
Thanks, Sergio. Here's a respiratory intubation question. Despite the use of maximal high flow O2 and of work of breathing that is okay, at what level of PaO2 do you intubate?
Yeah, so I think that if you can keep the PaO2 above 60, and somebody is not having an increased work of breathing, you're probably okay to watch them with COVID. And I think that what a lot of times happens, and what we're trying to advise against, is patients who are so the oxygen keeps going up, but not because they really needed it, because we were looking at the SATs or titrating too high, and without having like a good assessment, ABG, we just decided to intubate based on the fact that the oxygen went up. But I think that in general, if you keep your PaO2 above 60, you'll be fine. And the other reminder I have is that the tolerance to hypoxemia is something that's well documented, and we have to look at the whole picture. But it's very unlikely that below 60, they're going to get into trouble if you can sustain that with oxygen, as long as their respiratory effort and their work of breathing is not compromised.
Okay. Here's a question about hydroxychloroquine. Is hydroxychloroquine still being used in COVID patients despite the unfavorable Veterans Affairs retrospective study that came out in late April?
Yeah, I think that the answer probably is yes. I don't use it. I've never used it. I think that the data was not compelling enough to try something that could be dangerous for critically ill patients. I think that you don't hear much about hydroxychloroquine anymore, but the truth is that not only the data that has come out has not been very positive, but there's been increased reports of, I mean, especially when combined with azithromycin, that this could really cause real problems in terms of QT and in terms of potential complications. There's been trials that have been stopped because of harm. So I think that it's hard to make an argument that we should be using it. And what I would say, and I've been saying from the get-go, if any clinician is using any of these unproven drugs, including remdesivir, it is very important that we have very frank discussions with our patients or their caregivers, that we document these discussions, and that we obtain informed consent to use these drugs.
Okay. Last question, Sergio, this one's also going to be for you. Can one use closed circuit, non-invasive positive pressure ventilation in a non-negative pressure room if there were a vent shortage?
Well, the answer is yes, you can always do that. The question is that the best idea? And I think that ultimately, what we've realized in every hospital that is taking care of these patients is that the number of negative pressure isolation rooms we have is very limited. So invariably, you're going to eventually end up having patients who have COVID-19 who might require support in these rooms. And I think that there are things that we can do to minimize that. Proper use of PPE, tight seals, closed circuits, viral filters, etc. But the reality is, I think that nobody really has documented with COVID-19 what the real risk of aerosolization and contagion is with non-invasive positive pressure versus high flow oxygen versus a patient breathing on his own. A lot of what we assume is based on models and experiments, but nobody's ever been able to do it. I mean, nobody's done it with actual patients, but I would take the precautions as much as you can.
Great. Thank you very much. Any important closing words before we wrap up here?
As always, I would say thank you to everyone for all you're doing. And we create this for you. So if there's anything you'd like covered in future editions, please let us know.
Thank you, Nate.
Thanks,
Sergio?
everyone. Great job.
Thanks, Rob.
Just again, thank everybody. And for those of our colleagues, I mean, we obviously heard of two of them today, one via Rob's, very powerful email, and another one through the questions, who have dealt with COVID-19. Not only our admiration for all you've done for your patients, but also our most sincere, empathy in terms of understanding how hard it must be not only to deal with this as a provider, but to deal with this as a patient. And again, reiterate, our emails are always available. We're always available to talk. We don't have all the answers, but definitely, if there's questions that arise, please reach out. And if we don't have the answer, we'll definitely make our best effort to find somebody who can provide a better answer to support you. So again, thanks for everything, and anything that we can do to help, please let us know.
Thanks, Sergio. Greg?
Nothing to add. Everybody said it all. Thank you guys so much. Thanks for continuing to send the questions as well as your updates. And we look forward to continuing these, likely in a different schedule, but we'll look forward to continuing them.
Thanks, guys. Thanks, everybody, for listening and for all the great work you're doing out at the bedside. We'll talk to you in 2 weeks, I believe. So look for that invitation. Take care.